Okay, 2017 CPT. We start on page 66. It does say surgery guidelines, but it actually goes right into skin. It's all kind of combined together because there's only a couple of actual just surgery kind of codes. So let's look at the guidelines a little bit. Gives you some good information about what a surgical package is. Your book also talks about surgical package, follow-up care, that kind of stuff. Separate procedure. This is something that we'll talk about probably 3 or 4 times a month for the next 3 months, literally. Separate procedure. When you see a procedure, let's see if we can find one. Go to code 52,000, 52000. You will see, and this is, I'm just randomly picking it up, looking at a code, just so you can see how it's going to be written. This manual, across the board, if something is in parentheses, either in the code description or underneath, like down here underneath the code description, you better be reading them, because that's giving you hints on if you're unbundling, if you need to include another code, if you can code some codes together. Parentheses in this manual are vital. So here, this is telling us that this cystourethropy is a separate procedure. Anytime you see the word separate procedure in parentheses, you better stop and think about what you're doing. You cannot code a separate procedure with another code unless that other code is completely separate from what's going on. You cannot code a separate procedure with it. So you probably will always code the other code. If you have 2 procedures together, unless they're on completely different body parts and completely different procedures, you're not going to be able to code the separate procedure. So this is telling you that a lot of times if a code has separate procedure in a parentheses, that procedure may very well be bundled in the bigger procedure that you're looking for. I call those bigger procedures the big dog. And so you always want to find the big dog, find the big procedure first. That's ultimately what you're trying to find. Then if you come across these separate procedures, then you can say, I think that's a part of this other procedure. I better not code that. And then their separate procedures in parentheses is just a little prompt to help you with that thinking. Okay, these unlisted procedures are every unlisted procedure in the rest of the book, or in the surgery section, which is all the green. All the green is technically the surgery, all the way to the radiology. You don't really need to know this. They just put it in there. Again, here's your special report. Must really be important since we've already covered it 3 times. Here's some guidance on imaging guidance. And then surgical destruction. Okay, so here is the table of contents. You have 2 codes up here that are in the general or the surgery part. Then you go right into your integumentary. These pictures, this is where we really kind of start getting into pictures and stuff. This is a really good time to start labeling things, bringing in some of your medical terminology into each organ system, that kind of stuff. So here on page 71 starts our actual codes in the surgery section. You have 2 codes that are considered general surgery. Then we're into the integumentary. One is a fine needle aspiration with guidance, and one is without. The first one is without, the second is with. You see this is indented. So remember what we said about indented codes? The code description above it all the way to the semicolon, and then the code description by the indented code. That's the full description. So for code 10022, the full description of this code would read, fine needle aspiration, semicolon, with imaging guidance. Okay? Here's a good example of parentheses. So if I were going to use either one of these codes, I would be reading these parentheses like crazy to see if I could use it, or say it was on the breast. Maybe I needed to go to a different place. They did a fine needle aspiration on the breast, and it tells me, hey, you better go to this other code. Okay. Now, getting into the skin system, integumentary system. Everything in here is skin deep. Now, think about that a minute. Skin deep. We do have some codes that may go into the sub-Q, which is the fat, because we do have, see, sub-Q. But if you have a skin procedure that ends up going into the muscle, then you're going to have to go to the musculoskeletal. That's going to be over here in musculoskeletal because it's that deep. You always code to the furthest extent. And we'll say that a lot too. So let's just remember, we're just getting familiar. Just getting familiar. Okay, so we start in the skin. Generally, any headings that say introduction are a little bit of a catch-all. That's where some weird stuff can be. We have our incision and drainage. And then we read these codes are specific to certain kinds of scenarios, whether it's an abscess, a pilonidal cyst, foreign body. And we keep going. We have puncture, aspirations, incision, and drainage that are complex, specific to postoperative wound. Then we get into a debridement area. Again, we have guidelines and coding tips telling you to code to the depth. So here's all of our debridement. One thing about this book that I'm not crazy about, I love the pictures, but they put pictures in and it makes you think you're done with that section. But like this section, this description is for code 11005, which is this one. We also have a 11006 down here. So in the beginning, really get used to looking above and below all of the pictures. They can get very, very, very confusing. Okay, so then we're in here. We're still in a debridement. Very specific scenarios that are in here. I would suggest as you go through the exercises, they're just little one-liners that you're doing here at the beginning. But say your one-liner had a debridement of an open fracture, and that's what you were supposed to find. Debridement of an open fracture. Well, that's actually code 11010. So if I were you and I encountered this code, it's specific to a certain circumstance. It's not a generic code. So I would come in here just like I've done and underline that this debridement is for an open fracture and or open dislocation. So I can't use that debridement for anything else but that scenario. The more things that you highlight like that, not only is it training you to critically read every single description, it's also going to help your eyes flow through it. Oh, yeah, that's open fracture. Yeah, I remember that. Oh, that was for fat. Oh, that was for muscle. Oh, it was, see what I'm saying? And if you start that now, when you are encountering every single code that you'll come in contact with, you'll eventually get your own little collection of notes that are pertinent to how you read and how you interpret. Okay, paring and cutting. These are usually your corns and calluses, that kind of stuff. This is very, very, very specific to this action, paring or cutting. Okay? So this is, you would be able to pull out, the physician said, I paired 3 corns, or I cut 3 calluses off of the right foot, you know, whatever it is. Now we get into some biopsies. These are very generic skin biopsies. For these two, 11100 and 11101, you don't use a 51 modifier. So just make sure you kind of have a note there. You have 1 code for a single lesion, and then you have another code for each additional lesion. So this would be, say you had 4 lesions. Your first lesion is 11100. Your next 3 are 11101 times 3. So you can account for all 4 lesions. Skin tags. So if you're dealing with skin tags, this is specifically where you would go, nowhere else, even if they called them lesions, if they called them tumors, whatever. If the diagnosis says they're skin tags, they're skin tags. This area, shaving of epidermal or dermal lesions. Remember, those are 2 layers of the skin. Epidermis is on the top layer. Specifically, your technique is shaving. And it says these wounds do not require suture closure. So when you see that, they do not require suture closure. Okay, moving on into excision or removal of lesions, whether they're benign or malignant. I'm on page 75. This is a great page to show you 3 examples of how to calculate how big the excision is. The rule is, and I have it written here, you take the widest part of the lesion. So say the doctor said the lesion was 4 by 6. You're not getting square centimeters. It was 4 centimeters by 6 centimeters. That means this side was 4 centimeters, this side was 6 centimeters, okay? 4 by 6. So you take the widest, which is 6, hold that number, and then you take the narrowest of the margins. So say the physician said the lesion was 4 by 6, and I took 1 centimeter margins. So you would take the widest part, which is 6, plus the narrowest part of the margin. All we have is 1 centimeter. You double that margin, which makes it 2, and add that to the widest part. So 6 plus 2 is 8. So for the scenario I just gave you, you would find an excision for 8 centimeters. That's the size of your excision. And that's pretty much what all these 3 examples are telling you. The blue here is your actual lesion. This happens to be a melanoma. I know with melanomas, they usually do really wide margins because melanoma is so bad to get. So here the melanoma was just 1 centimeter, but they took 2 centimeter margins. So you take 1 centimeter, which is the widest part of the lesion, plus the narrowest part of the margin. The only thing we have is 2. You times that by 2. So your margins end up at 4 centimeters, so your total is 5. Okay, let's do the next one. The blue is your lesion. They say the lesion is 2 centimeters by 1 centimeter. So 2 is the largest or the widest part of your lesion. So now we put that aside and we look at the margins. Up here's 0.2, down here's 0.2. So we take the smallest margin, which is 0.2, times it by 2, which is 0.4, and add that to the widest part of the lesion. So your lesion comes out to 2.4. Let's do the last one. The blue is your lesion. They say it is 0.9 is your lesion. That's the widest part. That's the only number we have. Your margins are 0.3 and this one's 0.3, so they're the same. So you take 0.3 plus 0.3, which is 0.6, add that to a 0.9, so you get 1.5 for that total excision, measurement lesion, okay? So now that we know how to calculate the widest part of the lesion plus the narrowest part of the margin times 2 and then add them together, because that's our rule right here. Let's talk about the different lesions. So here we have excision of a benign lesion. Benign means it's not cancer. They go in and remove a benign lesion. They don't know it's cancer till the pathology report comes back. Hopefully it was sent to pathology. All excisions include a simple closure. You better underline that. They all include a local anesthesia. Okay? And then it defines what an excision is. Excision is defined as a full thickness, that means through the dermis, through the skin, removal of a lesion including margins, and includes simple closure when performed. So every code here includes the closure if it's a single layer. Now, if you look at these codes, this is very, very common for this book as well. If you look at code 11400, this is an excision benign lesion, except for skin tags, and then it gives you what I call a body grouping, trunk, arms, or legs. So all of these codes here are pertain to this body grouping. If we turn the page, there's 2 more that pertain to that body grouping. And then at 11420, we start another body grouping. This one is scalp, neck, hands, feet, genitalia. And then all those codes depending on size. And then 11440 is another body grouping. Face, ears, eyelids, nose, lips, mucous membranes. I would advise you, as you begin this, underline your body groupings so that when you know that you've got a benign lesion and you know it's on the face, if you have trunk, arms, and legs, you know it's not those. You come over here, scalp, neck, hands, feet, genitalia, you know it's not those. So you come here, face, lo and behold, there it is. You already have these underlined, you know to go to face, you plug in your size, you're good to go. Same principle with your malignant lesions. They all include simple closures. They have the same definition of what an excision is. Underline starting with code 11600, the body grouping there is your trunk, arms, and legs. Then you have all of those codes underneath there. Then starting, and remember, don't get freaked out with these pictures because there could have been a code up here. I've missed it. That's the reason I'm telling you. 11620, scalp, necks, hands, feet, genitalia. And then 11640, face, ears, eyelids, nose, lips. Okay? So this is the very same as your benign, but it's malignant. That means it's cancer. Now we get into nails. This is on page 78, nails. I have a little note here to use my HCPCS modifiers. What that means. Let's go to our little cheat on our front cover. On this second, second column on your cheat, down here at the bottom, well, starting here with your F's. F for fingers, T for toes. These are your HCPCS modifiers for your nails. That's the only place. You got nails on your fingers, you got nails on your toes. So F1 through F9, left or right hand, depends on which finger. TA through T9, left or right foot, depends on the digit. So they're already in here for you. So I just make myself a note because I'm bad about sometimes forgetting my modifiers. So I make myself a note and then I don't. Most of the notes that are in here are because I made an original mistake. And if I come to a code and I realize I've made a mistake, I make a note because I'll make that mistake again. We just all do. We all make the same mistake multiple times until we change behavior. So the first time I get there and I'm like, lo and behold, look at that. That said, you know, or and, or foot, or whatever. Underline it. So the next time you're there, you'll be like, holy cow, I've been here before. I can't use this. Okay, this is good advice. I promise you it will help you. Now's the time to cultivate those kinds of habits and those kinds of processes to find a code. Okay, pilonidal cyst, that is extremely specific. Remember I said your introductions have all kinds of catch-all freaky codes in them. If you can't find it anywhere else, you might want to check introduction. This one happens to have some injections, intralesional, tattooing, sub-Q injections like collagen, tissue expanders are in here. Also, your implantable contraceptive stuff is in here. It's just kind of a catch-all of stuff. Excuse me. Okay, moving into repairs. This will be fun. Okay, on page 79, you have definitions of a simple repair, which is a single layer. Intermediate repair, which is layers. It could be 2 layers or it could be 1,000 layers. Okay, it's just layered. 2 or 10 or 50, whatever. Simple, single layer. Skin is closed. Boom, that's it. Skin is closed. If they close the sub-Q and then they close the skin, you just became intermediate because that's 2 layers. They had to close the fat, which is the sub-Q, and then they closed the skin. Complex repairs. It tells you this is more than layers. Right there, more than layers. And then they give you some examples. Scar revisions, debridement of different things, extensive undermining. That means they've had to go in and really clean out a whole bunch of tissue. And then here are some examples, again, of what would be considered a complex repair. If I were you, I would remember that scar revision because you're probably going to come back here because of it. So remember where that was. And then here's your number 4. If your repair involved any kinds of nerves or significant blood vessels, then that would be a complex repair as well. So here we have them divided. Here's our simple, here's our intermediate, and here's our complex. Simple, 1 layer. Intermediate, layers. Complex, more than layers. Just like with our lesions, we have body groupings. So let's look at code 12001. This is a simple repair. Scalp, necks, axilla or axillae, which is right or left, external genitalia, trunk, and or extremities, including the hands. There's your body grouping. So every indented code underneath here pertains to that body grouping. It's just defined by size. I would underline all those body groupings so you can kind of make it through here faster. Code 12011, face, ears, eyelids, nose, lips, and or mucous membranes. That's your second body grouping. Your 12020 is the dehiscence. So a wound has come loose from a suture. Then we get into intermediate. Here's our body grouping: scalp, axillae, trunk, and or extremities, excluding hands for this one. Our simple included hands. This one excludes hands. 12041, repair, intermediate, neck, hands, feet, and or external genitalia. Our next body grouping, 12051, face, ears, eyelids, nose, lips, and or mucous membranes. And then we get into complex, same kind of process. So now that we know our closures, here's the next little thing that we can do with closures. Let's take code 12001. This includes hands and feet. I have a 1 centimeter cut on my left hand, and I have a 3 centimeter cut on my right hand. They're both closed simple. So I have 1, 2, 3, 4 centimeters of cuts on my hands. Because they're the same body grouping, in the same body grouping here, I can and the same closure, they were both closed, simple closure. I can combine them to 4 centimeters and code it with 12002. So one-stop shopping. Same body grouping, same kind of closure. You can combine. So you can combine a scalp with a neck, combine a scalp with a trunk, combine a hand with a foot, combine external genitalia with a foot. That would be interesting, but okay. So any of these body groupings, you can combine into one code if they were all repaired with the same closure. Now, if my left 1 centimeter was closed simple and my right 3 centimeters was closed intermediate, then I would have to do my simple here and my intermediate here. Now, how would I sequence that? Remember, we always sequence the most complex, the furthest extent, the most complicated first. An intermediate layered closure has higher reimbursement, is more complex than a simple. So that 3 centimeter intermediate closure would be sequenced first. Then I would put my 1 centimeter simple closure second with a 51 modifier on it because they're multiple procedures. Same type of problem, kind of the same body parts, but different. But the closures, it's the same purpose. They're closing. So that would be multiple procedures. Okay, let's say I have a 1 centimeter intermediate and a 3 centimeter intermediate on my hands. Same thing. I just go to intermediate. I combine my hands, 4, so my code would be 12032. Same thing with complex. Say I had those same lacerations, they were repaired complex. I can combine them both there if they're both the same kind of closure with the same body grouping. Okay, and I think I just told you wrong on that code because that excludes the hands. I hope you guys caught that. Hands are actually down here because this is a new book and I haven't underlined my stuff. So forget what I said about 12032. That was incorrect. 12041 has my hands, and so the real code would be 12042. So I bet someone caught that before. I just caught myself. Okay. Moving on. Good catch if you caught it before me. Okay, adjacent tissue transfer. Adjacent tissue transfer. Okay. There's some guidelines here. If I were you, I would underline your Z-plasty, Y-plasty, VY-plasty, rotation flaps, random island flaps, advancement flaps. At that advancement flap, Z-plasty and VY-plasties are probably the most common in here. Anytime you see documentation of an advancement flap or a Z-plasty, come here. Come here first and see if you can't find your code. Remember, we're still in skin. This is just skin deep, still in skin. Down here, here's a big rule, so really big guideline. The excision of a benign lesion or a malignant lesion is not separately reportable with these codes. That means if they have removed a benign lesion by way of an advancement flap, you code only the advancement flap. The excision of the lesion is bundled in. Okay? Is bundled in. So your notes or your op report might say excision of a, wish I had a pen where I could reach. Oh, I do. Oh, perfect. Yeah, you guys, we're just back to first grade here. Okay, here is my lesion right here on my hand. Can you see it? I don't want to color it too bad because then I'll look funky. Okay, here's my lesion. It is benign or malignant, doesn't matter. And they are going to cut it out, and then they're going to pull adjacent tissue over, squeeze it together. They wouldn't do this on a hand. They do this on butts and on thighs and where you have kind of extra loose skin. My hands, for as chubby as I am, my hands aren't very chubby. They're going to advance adjacent tissue over and close that with a flap, just like folding it over. So it's adjacent, to the defect, and then it's a flap. They're advancing the flap over. So you would not code the excision of this lesion. You would only code the advancement flap. So for a hand, say this was what? That's going to be probably about 2, 4, maybe 8 square centimeters there, maybe not quite that big. So let's say it was 8 square centimeters. This is on my hand. So let's find my body grouping. So I have a trunk here. That's not my hand. I have a scalp, arms or legs. And then I have a forehead, cheeks, chin, mouth, neck, axillae, genitalia, hands, and feet. So here are my hands. I said it was 8 square centimeters, the advancement flap, so it was 14040. Okay? And I don't code for the excision because they cut the excision out, but the big money was taking that tissue over and flapping it. Adjacent tissue transfer. Okay? So this is the big thing to learn here. They will make it look very attractive to you to code the excision as well, but you cannot do, you will get this on the board, I promise you. The stuff that I really pound out, you'll get it on the board. I promise you, you will. So learn the guidelines right off the bat, Okay, skin replacement surgery. Moving on. Now you'll have to look at my little benign lesion on my hand the whole rest of the video. Maybe the next video too, I may sit here and do another one. Skin replacement surgery. Different definitions. This is good guidelines, good stuff to read. Lots of terms to have to get familiar with in here. Autografts, tissue cultured autografts, what they include. Okay. And then skin substitutes. So we have 2 different kinds. We have auto or tissue cultured auto. So that's from humans or from yourself. Then you have skin substitute grafts. These are non-autologous human skin, which is dermal, epidermal, cellular, or acellular grafts. Homograft, allograft. These are good terms for you to go look up. Do a little bit of homework. Go look these up so that you're clear on what this is. We encountered this and had to have a 30-minute discussion on it in one of my former classes. So kind of educate yourself here. That's how we got all this underlined. But a xenograft is non-human. It's like a pig. Okay? Code 15002. This is on page 84. This is preparation of a recipient site. So there's 2. So sorry. Gosh. I hate that for you guys that you have to hear that. I really am so sorry. People are going to really gripe at me, and I'm sorry if I've been sick for 2 weeks and I I got to do the videos now. Okay, so you have two kinds of sites that are in here. One is your donor site and one is your recipient site. So let's talk about those. Donor site, it's a perfectly healthy site that is donating itself to the recipient. The recipient site has the problem. Oh, I guess we should do that since that was my benign. Let's do it opposite. This is my donor, and I'm going to donate skin to that terrible lesion that was removed. So donor donates, recipient receives. So really get that clear in your mind. So 15002 is the preparation or creation of a recipient site that's going to receive either skin graft from yourself, pig skin, a cellular graft, something. It's going to receive it. So let's say I had a terrible scar here on my hand. My husband has one terrible on his shoulder, but he's not here for me to show you. You wouldn't want to see it anyway. Okay, so say I have this terrible scar, and over time it has gotten so hardened that now I can't even open my hand all the way because that scar has just taken the skin and just made it hard, and I can't even open my hand all the way. So they're going to go in, cut that scar open, and then graft skin onto it so that eventually I can use my hand like normal. Probably going to be scarred pretty bad, but I'll have full use. I won't have the contractures anymore. So this code 15002 is them going in and creating a site that is able to receive a graft. So if this is completely healed scar tissue here, they're going to go in, probably cut out all of that raised keloid tissue, and then they may even, almost like a, you know, when you're pounding your chicken breast, you're pounding your cube steak, kind of pound it out, get it all juicy and really fleshy, meaty, and then they're going to lay that graft on there. And that graft immediately will be able to soak into all of that good atmosphere of a recipient site and then start growing and start attaching. Kind of a very graphic explanation, but that kind of tells you what it is. So what I do in here, now this area, the grafts, has remarkably gotten better. We used to have like 5 pages of grafts. Now we only have about 1.5 or 2. Really, really good. But what I do is under each heading, like this is autografts or tissue cultured grafts, I go in and I underline whether it's harvesting, a split thickness, epidermal auto, a split thickness auto, dermal auto, tissue cultured, full thickness. You see, so that my so that my eyes actually can flow better and faster through this material, so I can get to the code that I need to get to faster. Okay, then you're over in your skin substitute. Now here I would put a little note that it's pig or porcine. That's very, very common what you're going to see in here. And these, I don't underline anything in here. You certainly can because there's body parts and stuff. I just don't. When I know that it's a skin substitute, these are the only codes that you have to choose from. So it isn't as hard. The next section is different kinds of flaps, different fixing of flaps, delay of flaps, that kind of thing. You can find your thenar flaps in here. Say all the fat pad, you've lost all the fat pad off one of your fingertips. They may sew your fingertip onto this fleshy part of your thumb here and let it grow there for a few weeks. And then they cut it loose and you have your fat back here. And then this just kind of fills in. And that's a thenar flap. Very interesting. Then, of course, we got some other kind of weird flaps in here. And then thank goodness, then we're done with flaps. So that's kind of, these are more your free muscle, very involved grafts in here, composite grafts, that kind of stuff. Other procedures, that heading is much like your introduction heading. You're liable to find just about anything in there, I promise you. So introduction and other procedure headings is where kind of catch-all stuff is. In here, you're going to find chemical peels, and then like your excision of excessive or redundant. A lot of times you see that, redundant skin. This is for folks typically, well, not all, but some folks who have had a gastric bypass, maybe lost a significant amount of weight, have a lot of extra loose skin. And here is potentially where you would find the code to get rid of just that excessive skin. Then we're into pressure ulcers. Decubitus ulcers, they're the same. Adjacent tissue transfer is bundled into these codes, so maybe make yourself a note. If they are excising a decubitus ulcer or a pressure ulcer, that adjacent tissue transfer is going to be bundled into these codes. Then we get into some burns. You have a table here that describes an adult, an infant, and then a 5 to 9-year-old. It's divided by age across the top and then your body part here. And it just, this is the table of nines, and it just kind of sums up how much each body part is worth percentage-wise with burns. Destruction codes. A lot of times things are frozen off or burned off. Those are destruction codes. You generally do not see biopsies with a destruction code because they're destroying anything that would then go to pathology. You sometimes will see something called a representative biopsy, and they take a biopsy first and then they destroy the lesion, and then they're able to definitively figure out exactly what the lesion or what pathology they're actually looking at. So sometimes you'll see that lingo, representative biopsy. That just means they took a biopsy before they destroyed it. Most of the time, they're just destruction codes, so you would not see any pathology report. Okay, so we have some notes to make in here. Let's look at code 17,000. These are pre-malignant lesions that are being destroyed. An example of them they give you is actinic keratosis, or AKs. This code is for the first lesion. So if you only had one actinic keratosis destroyed, this is the only code you would use. Your add-on code here piggybacks onto the 17,000 code. I want you to underline each. This is the 2nd through the 14th lesion, each. That each means if you say you have 4 actinic keratosis being destroyed, your first lesion is 17,000. The next 3 is 17,003 times 3. Okay, really back up and listen to that again. This is each, so you will times this out to the 14th. So if you have 14 lesions being destroyed, your first lesion is 17,000, then you have 17,003 times 13. 13, 14, 14, 15, however you want to say it. Well, up through 14. So this is 13 is as many as you could put on this, because 17,004 starts with the 15th. So if you have 20 actinic keratosis being destroyed at the same time, you would only use this code and only this code. It's telling you here in parentheses, do not use this code with these other 2 codes. Do you see how the parentheses are very, very important? Anytime you think you've found the right code, you need to start reading above and below all the parentheses and make sure that you're in the right place, you've gotten the right code, and you don't need something extra. Code 17106, these are vascular lesions. This is like a port wine stain, maybe on the face. I put port wine just to kind of flag my brain. And then 17110, these are for warts, whether they're plantar or viral, not HPV warts. They're not on your privates. That's completely different. But these are just skin warts, other than skin tags, other than vascular. Remember, your vascular's up here. So these are just plain old seed warts that may be on your knees, on your elbow, on your fingers, wherever they are. All right, let's talk about Mohs. This is on page 92, Mohs. Mohs, this kind of gives you a little history of what it is. Mohs combines the surgery and the pathology all in one. So the dermatologist or whoever the surgeon is, maybe there's a surgeon and a dermatologist in there at the same time. However they have it worked out. They take a slice, go look at it under the microscope, and they take slices or blocks until every part of that block, every part of that biopsy or that skin is completely clear of the lesion. So again, these are divided by body parts. So your 17311 is your head, neck, hands, feet, genitalia, or any location directly involving muscle, cartilage, bone, tendon, major nerves. You generally won't see that. Mohs is generally just the skin. This is for the first stage. We'll talk about that in a minute. Up to 5 tissue blocks. We'll talk about that in a minute. Your add-on code is each additional stage. After the first stage, up to 5 tissue blocks in that additional stage. We'll talk about the stage and blocks in a minute, but let's just get through these codes first. 17313, your body part is trunk, arms, or legs. First stage, up to 5 blocks. Your add-on is 17314, each additional stage. After the first, up to 5 tissue blocks. So, here's this lesion, and we've determined that it's cancer now. So they're going to go in. Where's my hands? My hands are up here under 17311. So make sure I get the code right this time. So they're going to take, this is the first stage. Each stage can contain up to 5 blocks. So they're going to take a slice, go look at it under the microscope. It still has stuff in it. Take another slice, look at it. Yep, still has lesion in it. Third slice, look at it. Fourth slice, look at it. Fifth slice, look at it. So code 17311 is the first stage up to 5 blocks. So at that 5th block or 4th block, whatever, if it's completely clear of lesion, then you're done. That's your code. If after the 5 slices, they have to take more slices, they have to keep going, then they start a second stage. And so then you have an add-on code for the second stage, after the first stage, up to 5 more tissue blocks. So they can do blah, 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 blah. 5 of those in the second stage. And then if you're clear, you're done. Now, let's say that they were in the first stage and that 5th tissue block was just about clear. There was just a tiny, tiny bit of lesion left in it. And the doctor didn't think he needed to go to another stage and go up to 5 again. He just thought maybe 1 more tissue block, maybe 2 more, and then they'd be good. So this add-on code 17315 is each additional block after the first 5 blocks any stage. So say 17311, the first stage, they've done the 5 and it's just almost gone. They need to do 1 more block. Still in the first stage, but just 1 more block. So they take that, lo and behold, it's all clear. So you would code it 17311 plus 17315. This is an add-on code which would piggyback onto either the 11 code or the 13 code. Okay, so that's Mohs in a nutshell. If you live in Florida, you probably see a lot of people that have had Mohs. Okay, a little bit of cryotherapy. Let's get into the breast. We love the breast. A little bit of terminology to get used to. If you see a physician that's documented excisional biopsy, you do not code that biopsy, you code it as a straight excision. Okay, excisional biopsy code is a straight excision. Also, since the breast in normal healthy people, whether they're male or female, they have 2 of them. Okay, so you're going to have to use a 50 modifier. If they've provided procedures on both the left and the right breast, then you would probably need a 50 modifier on it. Okay, so we have an incision heading here. Just different incisions that might be made into the breast. We have lots of, we move into excision, we have lots of guidelines. Moving into the excision, you'll get some good practice in here to kind of read some of this. You'll get to underline some of the breast localization devices and that kind of stuff. So there aren't a whole lot of codes in here. I'm just going to let you, I think the book does a good job of kind of getting your feet wet in here. Again, here is an introduction section. So remember, that's a catch-all, just like your other procedures is a catch-all. You have, in this introduction section, you have your localization devices, different than maybe what you saw over here. You'll have to read the differences. Then we move into mastectomy procedures. I do a lot of underlining in here so that I can get straight in my mind the extent of the mastectomy, because you can have a partial mastectomy, which is really just a lumpectomy. They just took out a little lump and you're fine. Or you can be all the way to a radical modified, to where you have no breast tissue, you have no lymph nodes, you're just kind of all the way down to the rib cage. You don't even have much of your pectoral muscles left. Okay? Your 19301 is a partial, that's like a lumpectomy. You would have to track left or right. If they did it to both, it would be a 50 modifier. Then here's a simple complete. Again, track your left and rights in here. In fact, you can even put left or right if that helps you remember. And then maybe a question mark. Subcutaneous mastectomy, and then a radical, and it tells you the definition of a radical, and then a radical including, so these are 2 radicals, one's more extensive than the other. This is the urban type, and then your modified radical. Then you have your reconstructions. Your reconstructive breast surgeries, if you're just doing it for augmentation, aren't going to get paid by insurance. They are in here because if you had a mastectomy, you may very well want to be reconstructed so that you have breasts again. That is obviously paid for by insurance, because it's not just for cosmetic reasons. And then you have some augmentation, and I think you have in here, you have some not augmentation, but some reductions in here too, which typically if you have some type of back issues or something, shoulder issues, neck issues from large breasts, then insurance, would pay for them to be reduced. Just not if it's for cosmetic reasons only. One note that I do put in here, and I put it over here, when they go to potentially do a breast biopsy, kind of how that flows is maybe in the morning you show up at the hospital and they go in and they're going to put a little metal clip in or a little localization device first, and they're going to use some dye called dye for the sentinel node. And this is code 38792, and I put that here so I don't have to go digging for it. So so in the morning they may do the localization, put in a clip or put in a marker to show where there may be potential problems. They inject this dye in there, and then in the afternoon you are actually going to have that biopsy done. This first part was just to kind of put down the roadmap to where the surgeon needs to look. The dye that they put in will, you'll have an uptake for where there's the abnormal cells or where there could be a problem. And so they wait a few hours in between so that when the surgeon gets in there, he knows exactly where to go, exactly where to cut, where to get the best biopsy from so that they can make the most accurate diagnosis. So I put that here just so I don't have to go dig it up. Okay, and you have made it, believe it or not, through the integumentary. Can't believe it. So we are on to musculoskeletal next.